Hi, everybody. Dr. Daniel. And today I'm podcasting on persistent aura without infarction. What is persistent aura without infarction? Very rarely a patient with migraine with aura will experience a persistent visual aura, and it's usually present in bilateral visual fields in central vision and superimposed on normal vision. As defined by the International Classification of Headache Disorders 3, persistent migraine aura without infarction is a rare but well-documented condition. There should be persistence of migraine aura for more than 1 week without radiographic evidence of infarction. The patient should have migraine with aura and typical previous auras, except that one or more aura symptoms persist for over a week. Neuroimaging shows no evidence of infarction, and it's not accounted for better by another ICDH3 diagnosis. Persistent aura symptoms are rare but well documented. They're often bilateral and may last months or years. So what's the difference between the auras of migraine without aura and persistent aura without infarction? Symptoms of aura with migraine should last less than 60 minutes. So, migraine with aura is recurrent attacks lasting minutes of unilateral, fully reversible visual, sensory, or other central nervous system symptoms that usually develop gradually and are usually followed by headache and associated migraine symptoms. And these symptoms could be, the aura symptoms could be visual, sensory, speech, and or language, motor, brainstem, or retinal. At least 3 of the following characteristics have to come. At least one aura symptom spreads gradually over 5 minutes. 2 or more aura symptoms occur in succession. And each individual aura symptom lasts 50 to 60 minutes. At least one aura symptom is unilateral. At least one aura symptom is positive. Like with visual attack, they'd see spots or holes. At least one aura symptom is accompanied or followed by headache within 60 minutes or so. The comment regarding spreading gradually is important in that migraine does this. It moves from place to place on the body. If the aura starts as a visual aura, say a zigzag line, the line may appear far laterally and move slowly centrally in the vision, while a TIA or a stroke or infarction involving the central retinal artery in the retina, it doesn't move. It just comes and either goes if it's an embolus or it stays if it's a stroke. If it's a TIA, it comes and stays for a while. If it's stroke or infarction, it stays permanently. This is an important, usually helpful clinical sign differentiating stroke from migraine. The other important bit here is the ICDH3 limit of 60 minutes of time. Less than 60 minutes is okay, and usually the symptom then remits, like a migraine visual attack should do. But persistent aura attacks, by definition, have to last longer than 7 days or a week. If the migraine aura is a sensory symptom, the paresthesia or numbness may start in the fingers of one hand on one side of the body. The numbness moves from finger to finger, clearing up in the first involved finger as time goes on, moves across the fingers. Then the numbness goes to the arm, the upper arm, then the cheek, lips, gum, and tongue on the same side. This is the migraine movement characteristic again. So one-sided or both-sided bilateral. A migrainous aura symptom of numbness is usually only on one side of the body, like the right hand, fingers, arm, upper arm, or face. It's because the event is occurring in the opposite parietal lobe of the brain for that person. Left parietal brain symptoms cause only numbness, like the patient perceives in the right hand or the cheek. Rarely the patient perceives numbness on both sides of the body for migraine sensory symptoms. A migrainous visual aura, however, is usually seen in both eyes because the event is occurring in the occipital part of the brain in the back of the head on one side. The patient usually only perceives the visual event on one side, however. An aura event originating in the left occipital brain might be perceived in the visual field of the left lateral eye, which will be dominant, but there will be a less noted aura occurring in the nasal visual field of the right eye. And patients should be instructed to notice this. Always ask patients to close their eyes and see if they can see it in both eyes. Neuroimaging for these events. This usually should be an MRI scan with contrast, which is a better test than CT scan to review a stroke at this kind of deal in the office. The patient should have a previous history of migraine with aura events. This doesn't always happen, but the neurologist should seek from the patient a history of previous events of migraine with aura. A frequent possible exception here is a female patient who had previously experienced migraine before, just plain migraine, but only migraine without aura events. Then her OB puts her on estrogen-based birth control pill, and during her next menstrual cycle, she has her first scary migraine with aura event, which brings her in to see the neurologist. This type of patient is a serious, immediate, fragile patient who is now, because of the migraine with aura event and on the pill, at great risk for an imminent stroke. And she should be advised to get off the pill that day to never take it again. Persistent migraine with aura without infarction and what's called visual snow. The first case of persistent migraine with aura without infarction was described by the famous neurologist and writer Oliver Sacks in 1970. Later, the neurologic literature mistakenly mixed persistent aura without infarction and what is called visual snow. The first textbook I wrote, Migraine, published in 2014, carries this error because that was what was thought at the time. But the two medical conditions are now not considered to be connected. They're understood to be two separate medical disorders. So visual snow is a neurologic disorder characterized by continuous visual disturbances that occur in the entire visual field and described as tiny flickering dots that resemble the noise of a detuned analog television. Visual snow has been misdiagnosed in case series, been mixed with persistent migraine aura, which has led to a mechanistic confusion, diagnostic imprecision, and certainly the use of treatments have not been useful. Visual snow disorder has been considered to be the same condition as hallucinogenic persistent perception disorder, although it seems hallucinogens can trigger a similar disturbance. It is clear visual snow syndrome can be entirely independent of drug triggers. Lastly, many patients are told they simply are normal. Admixing these issues has delayed recognition of the syndrome. Literature review of persistent visual aura without infarction. Again, this rare migraine syndrome was first described by Sacks in 1970, and he wrote, quote, that recurrent cycles of paresthesia may follow one another for hours on end, on alternate with cycles of scotoma in a migraine status, end quote. Then Haas, in 1982, writing in the Annals of Neurology in an article entitled Prolonged Migraine Aura Status, described two patients with migraine who experienced a prolonged migraine aura status consisting of frequent recurrence of auras, hour after hour, day after day, for successive weeks. One of Haas's patients was an 8-year-old boy who had experienced typical migraine with aura attacks for a few years. He usually saw a, quote, bright zigzag arc, end quote, that moved and twice, quote, a stationary bright arrowhead figure in the left visual field, end quote. The aura was usually followed by right or left suborbital headache, photophobia, nausea, and sometimes vomiting. Haas described what happens next. And this is a quote from him. In October 1978, this patient began to experience a new visual phenomenon unassociated with headache. It burst into his vision in the form of concentric gray circles like ripples in a pond. Each attack lasted several seconds. The circles were faint and, though annoying, did not obstruct vision. Originally, he saw a set of concentric circles in front of him, but later saw clustered sets of concentric circles in the right visual field. For about 2 months, these clusters appeared frequently but irregularly, and sometimes followed one another closely for hours. During 1 2 weeks period, attacks were unremitting, and he saw about 100 clusters each day. In February 1979, attacks became infrequent, and by April they had disappeared completely. 13 years later, Liu et al., writing in Neurology in 1995, reported the first large series with 10 patients in a paper entitled Persistent Positive Visual Phenomenon in Migraine. Since then, there have been many articles and comments on treatment. An article by San Juan and Zimmerno in 2007 in Cephalalgia describes persistent aura in a 28-year-old Mexican patient. This man had a 24-year history of migraine and presented with persistent aura symptoms described as scintillating scotomas, bilaterally associated with photopsias and amaurosis followed by migraine headache. Neurologic imaging studies were negative. The episode lasted 35 days and probably resolved with nimipodine calcium channel therapy. Case report. Wei-Tay Chang, Lin, and others wrote an article in Brain in 2011, and this is their abstract. Persistent aura without infarction, a rare migraine disorder, is defined by aura symptoms that persist for over 1 week without radiologic evidence of cerebral infarction. To unveil its pathophysiologic mechanisms, this study used magnetocephalography to characterize the visual cortex excitability in persistent aura by comparison with episodic and chronic migraine. We recruited 6 patients with persistent visual aura, 39 patients with episodic migraine in the ictal phase, and 27 in interictal phase with aura, 18 patients with chronic migraine, and 24 healthy controls. 5 sequential blocks of 50 neuromagnetic prominent responses were obtained, and the dynamic change in visual cortex excitability was evaluated by the percentage changes of individual amplitudes. In terms of other migraine spectrum disorders, persistent aura differed from episodic migraine in the presence of ictal potentiation. Persistent aura further differed from chronic migraine in the absence of interictal potentiation in chronic migraine. There was a higher percentage change of response of amplitude in the end situation in persistent aura than in chronic migraine. Then we had Luda, had a patient who saw scintillating geometrical figures in the shape of either rings or chains. His patient, a 29-year-old woman, experienced sudden disorientation followed by stars filling the visual field of both eyes, followed by a diffuse, non-pulsating headache. These stars lasted 5 months and then disappeared. Ruthrock saw a patient who had a severe, prolonged migraine for 2 months associated with jagged zigzags like crushed, broken glass to the left of a scotoma in her left visual fields. Some patients have experienced numbness and tingling on the same side of the body as the visual image. The following is a detailed description by one of Haas's affected patients. I'm a 24-year-old female and starting to feel out of it around 8 months ago. I finally identified the out of it feeling as being a change in my vision. It's as though I have tunnel vision. I can make out whatever I am focusing on, but everything around it seems splotchy. It seems to have gotten worse over a period of time, and 6 weeks ago I had an episode of flashing lights, blind spots, and wavy lines in my right hand field of vision for both eyes. For about 30 minutes, sounds like the symptoms of an optic migraine. The splotchiness in my peripheral vision never goes away. It didn't seem to be preceded by anything. I can't pinpoint a possible trigger. So this is the end of my comments on this unusual persistent aura without infarction situation. Thanks for listening to this. Please click on subscribe and follow me on other podcasts I have. God bless all you women that have migraine, any of you that have this weird persistent aura, the migraine thing. And I'll see you again on the next talk.